I'm Heather, I'm a psychologist and I work in an adult sickle cell service.
Hello, I'm Maria and I'm a psychologist as well, and I work in paediatric sickle cell service. And today we're going to be talking about the psychological aspect of acute pain. And we start with the basic scientific view that mind and body, and as you can see on the slide, we can't separate them. Who we are and who we feel we are, it's both influenced by our mind and our body. Our mind influences our body and our body has an impact on our mind.
And there are so many factors that affect a person's experience of pain. One of the key psychological factors is stress. We know that stress makes pain feel worse, and it also has an impact on how somebody copes with their pain as well. So when somebody comes into hospital with sickle cell, they're going to experience an awful lot of stress potentially. They're going to bring it with them, and there's going to be stuff that happens in the hospital. Some of the key things that patients tell us is that they can feel that they're not heard, they feel stigmatised, they can even have a sense of a fearfulness of safety, and they can sometimes feel like they're having to fight for care. This can all affect stress, and that will affect their experience of pain. So what does sickle pain feel like? Our patients tell us that it can feel like someone's got a hammer and hammering into you. They're smashing it into your body. Some patients say that the pain can be so bad that they just want to die. And other patients may say that they think about family or relatives, friends who have died when they've had a sickle crisis. And all of that will be really stressful while they're having their sickle crisis, and that can make the pain feel worse.
And many of the children and the young people, they share some of these descriptions. And speaking of pain, it makes me think that when they come to the hospital, and especially to A&E having acute pain, alongside the pain, they bring their stories, as we can see on the slide, and they bring all these different stories. And some of them may be financial difficulties, worries about work, worries about missing school, racism. Some of them may be traumatic. And it's really important to keep at the back of our minds if there is previous trauma in their lives, either health-related trauma or any other kind of trauma, because that would present with fear, anxiety, stress during future contact with healthcare professionals. They may appear to be tearful, defensive, aggressive even sometimes. And it's really important for us to try and provide a trauma-informed care, so we help them reduce this stress when they come to the hospital and build a sense of trust and safety between the patients and ourselves, the clinicians.
So what we've just been talking about, we can visualise as something we've called the sickle trauma tree. So the branches, the leaves, that represents the behaviour that we see, and also the emotions that people are expressing when they're in hospital. And alongside that, sometimes there might be labels that happen. So somebody might be deemed to be a difficult patient. But what we don't see is everything that's happening underneath. Under the surface, and that's represented by the roots.
Yes.
So a lot of the things that you've already said are there on the slide, lurking underneath the surface. Things like experiences and memories of being in hospital before. There might be things like publicised deaths that come to mind when people come into hospital. And also racism, discrimination in the hospital, but in other contexts as well. So we've talked about the experiences that people might have before they come to hospital, or memories of experiences in hospital. But when somebody's actually in hospital having care for their crisis, there might be things that happen that add to their stress, and that will then add to their experience of pain. Things like not getting their painkillers on time, ending up in a ward that's really cold, or being placed under vents that makes it cold, not having access to things that can make them more comfortable. And it may be that staff in the hospital may not be as aware of sickle cell, and also there may not be always that joined up approach that we would hope there would be when looking after patients, and that could be stressful too.
That's also shared by the children and young people that we see, the joint care, especially when they have to go to different hospitals. And that also makes me think about the power of language, because even though language has no physical power, has lots of power, and it's important to keep in mind that certain words deprive patients their own, individuality. And some of them words that we use in relation to treatments may have negative connotations. And it's really important to be mindful how we speak about our patients when we think that they can't hear us. And it's really important also to keep in mind, especially with children and young people, because a child is never alone. They come always with a parent, how parents may present on the ward, as well as children, and they come to A&E with acute pain, having a variety of presentations and feelings, and it's always to be mindful that regardless of the variety of the different presentations, the acute pain is there.
A lot of what we've talked about so far came together and was put in a report that was called No One's Listening. This was published in 2021. And one of the key things that came out of this report was that there were frequent reports of negative attitudes towards sickle cell patients. And the evidence suggests that such attitudes are often underpinned by racism. So it was really named in this report. And of course, all of that will affect people's experience when they're in hospital and of their pain. So we've talked about what can go on for somebody when they have sickle and they're in pain. Now we're going to talk about what can staff do to support them.
Yeah.
So the most obvious thing is when patients ask for more painkillers, it would be so helpful if people recognise what judgments they make at that point. We know that stigmatisation and overestimation of opioid abuse and addiction by healthcare teams occurs. So it's just so important that staff notice that they're thinking, well, why is the patient asking for more painkillers? And the most likely reason is they're trying to alleviate their pain rather than it being because they're looking for some drugs to feed some sort of addiction. And patients always say that they want to be involved in decisions about pain management.
And that makes me think of care plans, because all the adult patients, if I'm not wrong, they should have a care plan. And part of the care plan is analgesia and management of pain when they come to hospitals. And children and young people not always have a care plan, but it's always good to ask the parents and the child if they have a care plan, because some of them may have a care plan done collaboratively with the child or the young person, especially if they have learning difficulties.
And the care plans that we create, sometimes we can add to them and include things that the patient says that they particularly find helpful with their pain. So things like distraction, listening to music, watching videos while they're in hospital, learning some relaxed breathing, calling friends, keeping warm, massages. So all of that can be put in the care plan as well as a reminder for the patient and staff about what helps with their pain. We've talked a bit about patients bringing their emotional baggage into hospital, but we're all human and staff will have their own emotional baggage as well. So one of the things that we always think can be really helpful is for staff to notice how they feel, so how we feel when we're with a patient. So if a patient is asking over and over again for something, of course we might feel frustrated, we might even feel a bit angry. It might be really hard to tolerate sitting with somebody who's really upset. Sometimes we can have an urge to rescue or fix the patient, or at other times we might have an urge to avoid them. So we can get pulled into a particular role depending on our past and our experiences. So we as psychologists are used to doing this and noticing how we're feeling in a situation and being curious about it. And I think it would be really helpful if staff who care for patients on the wards can also get into habit of noticing that as well, because then that helps them to be able to respond in a thoughtful way to the person and what they're asking for. So what else can we do? We came up with some principles of good sickle care based on the trauma-informed approach. and came up with some things that really try to help to build safety, trust, choice, collaboration and empowerment. So what patients always tell us is treat us as an individual, take our pain seriously and give our pain relief promptly. Patients know often that they have a care plan and they really want people to follow it. They want their expertise to be used and to be asked what helps in that situation. They want their concerns to be listened to really fully and for people to put aside judgments, to validate their experience. It can be really helpful for staff to check that they've understood what's going on and being really clear about the next steps. But also what's important is really clear communication, and this could be adapted to that individual's needs.
And also following up onto what you're saying, keep our promises as clinicians to do what we're saying we're going to do. Be open and honest and try to repair if there have been any ruptures in our relationship with the patient. Because as you said, we're humans. So mistakes will happen, especially on a busy ward like A&E. But try to repair any ruptures in their relationship. Give them choice, give them information and give them a choice to make an informed decision. And always consider what else is going on in the patients and the families when it comes to children's lives. Last but not least, very important, try to create a safe and containing environment. Thank you for having this conversation.